Good morning. Hopefully you can hear me. If someone can give a thumbs up in the Zoom room or in chat. Excellent. Thank you, Bernie. You're helping with our test sound. Excellent. Well, good morning and welcome back, everybody. My name's Daniela Friedman, and I'm professor and chair in the Department of Health Promotion, Education, and Behavior in the Arnold School of Public Health at the University of South Carolina. I'm also one of the principal investigators of our Carolina Center on Alzheimer's Disease and Minority Research. I'll be introducing our next speakers and moderating this session. The speakers for our next session have become dear colleagues, and they are Ms. Rana Bayakli, Dr. Maggie Miller, and Dr. Bernie Schwerz. Ms. Bayakli is the chief epidemiologist at the Georgia Department of Public Health, Chronic Disease, Health Behaviors, and Injury Epidemiology section. As part of her role, she's the principal investigator for the Georgia Violent Death Reporting System, director of the Georgia Comprehensive Cancer Registry, and manager of the Georgia Alzheimer's Disease and Related Dementia Registry. Dr. Miller is a research assistant professor in the Department of Epidemiology and Biostatistics here at the University of South Carolina and the South Carolina Alzheimer's Disease Registry Manager. She's also co-director of the University of South Carolina Office for the Study of Aging, which houses the oldest and most comprehensive registry in the United States. Her research is on Alzheimer's disease and caregivers of individuals with dementia. Dr. Schwerz is a professor in the School of Medicine in the Department of Neuroscience and the Rockefeller Neuroscience Institute at West Virginia University, and he is the director of the West Virginia Alzheimer's Disease Registry. As you can see, we have a very esteemed group with us for the next session. Our speakers will lead this session entitled Introduction to Statewide Alzheimer's Disease Registries. Each speaker will have up to about 15 minutes to present, and we will have time for questions after that point. Please feel free to enter questions along the way in the chat so you don't forget them, and we will have a nice discussion after each of our presentations. So we will start with Rana, and we will share our screen, and we will help advance the slides. Just give us a moment.
Thank you so much. Thank you so much. Appreciate it. I actually enjoyed the morning session. It was very engaging and very helpful for me. So I do thank you so much for organizing this meeting. So as the registry manager at the Georgia Department of Public Health, if we go next, please. We had our, next, please. We had our law that passed in 2014 and has been revised several times in order to allow us to share and use data better with our partners and academic institution. But part of what we have done in the registry to collect and disseminate data is really establishing two ways of reporting. One is through our physician portal, and the second one is creating an HL7 message, which is implemented within an electronic health record, allowing reporting to come directly from a facility or an electronic health record to come directly to the state registry. We are currently in the process of getting this active type of reporting from various healthcare providers and hospitals in Georgia. To date, we have about 5 hospitals that are reporting using the HL7 messages, and we are going to be adding about 3 in the near future. We also used our cognitive impairment or cognitive decline module in the caregiver module on the Georgia Behavioral Risk Factor Surveillance System, as these 2 modules have helped us a lot in planning, and we have been consistent adding these modules in alternative years since 2011. We also have recently established a mechanism for disseminating data by putting our data in a dashboard, and I will be sharing how to access the dashboard for ADRD death and morbidity from both hospital discharge and emergency room visits, as well as we request and receive data from CMS on the Georgia population that have ADRD with their comorbidity and cost. So data so far, what we've been doing with the data, and since 2014 or establishment of the registry, we have done a lot of burden reports or fact sheets, shared those, describe in general demographic characteristics. We've looked at chronic disease, comorbidities, preventive measures, since it's on the Georgia Behavioral Risk Factor Surveillance System, such as vaccination, suicide or mental health, and gun safety. We looked at screening, and we looked at risk behaviors and healthcare access. With our data available on our dashboard, you are now able to actually trend the data all the way back to 2000 or 1999, based on which data set you're using. And you can look at the data by demographic, by geographical location. We have done a lot with the caregiver and with our GARD, or the Georgia Alzheimer and Related Dementia Collaborative. They're divided into various subgroups in the state of Georgia. And we have worked with the workforce development, looking at our caregiver module, describing who are our caregiver in the state of Georgia, and then their health risk behaviors and health conditions, as well as their access to care. So the GARD workforce development have used the data for planning purposes. We also work a lot with research. We do our own analysis, as well as we work through the healthcare data and research work group of GARD to produce research that is of their interest. So currently, we are working on a trend data looking at ADRD death through the years from 2000 to 2019. We stopped before the pandemic to just look at how primary cause of death assigned as ADRD has changed through the years. So the article or the research will be published in the near future. Other research that we have worked on in collaboration with our research subgroup or work group would be falls among ADRD patients and the Medicare population. We looked at the various distribution, geographical distribution, urban, rural, and we actually have linked our data sets, because we have other registries within my unit, linking it with the Georgia Violent Death Reporting System, and looked at suicide among the ADRD population, timing of the suicide, and the mechanism or the weapon used for the suicide. All this research really shared with the safety work group of the GARD, as one of the findings was patients who were early diagnosed with ADRD were more likely to die of suicide or more likely to use a weapon. So one of the safety measures that we work on is working with the caregiver when the patient was first diagnosed with Alzheimer or any ADRD, and had accessibility to gun to do more awareness on gun safety. We also work with our academic institution, primary, Emory, and the Georgia Memory Net to continue the discussion or to participate in the discussion related to early staging and early diagnosis of ADRD. Next, please. So based on our law, that is kind of the purpose. Our law is establishing a registry and using the data, share the data, and see how the registry can facilitate reaching caregiver, ADRD caregivers. So one of the good news we have in Georgia that has been created recently is creating a dashboard that adds the ADRD. So normally, if you go on our website, which is the Georgia Department of Public Health, and you work on OASIS or the online analytical statistical information system, you used to have only Alzheimer's disease as part of all causes of death. What we have done is created this dashboard, as you can see in here within the mortality morbidity box, and we added all the related ADRD ICD-10 codes. And also in that, if you go to this community health, we had the opportunity to add Alzheimer and looking at the 10 leading causes of death in the state of Georgia. And now you're able to quickly click on it. And as you could see from our data, it is our 5th leading cause of death in Georgia. So again, if you go to our Alzheimer's disease and related dementia, you click on this box. It opens for you another box where you can have statistical information, number, crude rate, age-adjusted rates for death, morbidity from hospitalization, and morbidity from ER visits. You can trend it, and you can do it by rural, urban, and in Georgia, we're divided into 18 administrative public health districts. So you can download the data, raw data. You'll be able to download it and use the data if you would like, without coming back to us and requesting the data. So that makes it easier access to researcher who are interested in doing further analysis related to death and morbidity from ADRD. You can map the data for those 3 sources, and you have an easy access for a trend data for ADRD and each of its subcomponents. So it's not necessary just as a group. You can look at the various components and trend it. If there is enough data, it will trend it for you, and it will give you the demographic information. And the demographic information is normally race, ethnicity, gender, education, as well as payer, when the data set allows for that analysis to be done. Next, please. And one cool thing that I believe should be very useful and could be helpful for everyone who would like to use our data, you can actually go on, again, on OASIS and go to any one of these categories, either mortality, hospitalization, or ER data, and you can download the data to the census tract. You can combine years, or you can send it, you can download it year by year. And then we have another tool or another layer that you could use the social vulnerability index as a health equity measure. At that point, we have only socioeconomic status, but you can download it, or you can go to this website at the bottom where you can actually download all the vulnerability index with all its factors, those 16 factors that you can see, and do analysis with the death data or morbidity data. Next, please. These are some of our products, and that data could be used in all of these type of product. We used it for planning purposes. We work with the Division of Aging Services and produce data by their AAA regions. We have given them weighted data from the behavioral risk factor in order to help for planning purposes and provide services in the areas based on the number of estimated cases for ADRD. We produce fact sheet for legislator and the public. We had the reports that's normally used for funders and partners. And we did support our BOLD grant funding process. So we provided a lot of data in order to help them receive the funding for them to be able to conduct activities. And of course, we do have a lot of research, and these two are the most recent one, as we have occupation and industry on our Georgia Behavioral Risk Factor Surveillance data, and we were able to look at occupation with cognitive decline. Next, please. So in general, how would I, what I would like to see the registry doing in the future, in addition to data dissemination, data analysis, and facilitating the use of data, what I really would like is to have our registry fully funded, where we're able to actually receive data directly from all providers and be able to consolidate, edit, and use the data more into a patient type of registry and not just bringing data from different data sets. I would really like to support other states doing registries or implementing registries, as the more we implement registry, the more likely you have the support for registry, the more likely you have data, good data disseminated, and people start really thinking of how to support activity related to preventions and intervention. My dream is that one time we will have this professional association for registry, for ADRD registry, where we talk mainly focus on data collection, data standardization, and data use. Thank you.
Thank you so much, Rana. Appreciate your sharing your expertise with us. And we're going to move on to Dr. Miller's presentation. Welcome, Maggie.
Thank you very much. And thank you, Rana, for all of your details about the Georgia Registry. My name is Maggie Miller, and I am the manager of the South Carolina Alzheimer's Disease Registry. So I'm going to give you a brief overview of what we're doing in our state. Next slide, please. Thanks. Okay, so the South Carolina Alzheimer's Disease Registry is a unique resource for statewide ADRD surveillance and research, and it's an asset for community planning in both health and social services. Our registry collects data from established secondary and administrative sources about individuals diagnosed with Alzheimer's disease and related dementias in our state. A previous chair of the epidemiology department at USC, Dr. Carol Macera, had the foresight to see dementia as a growing issue and challenge for families, communities, and service providers in our state. She founded our registry way back in 1988, so this makes it our 35th anniversary. Quality that makes our registry unique is our legislation. In 1990, the governor signed a state law authorizing the establishment of a voluntary statewide Alzheimer's disease registry. The law has strict confidentiality requirements for data collection using existing sources, but it does allow registry staff to contact the families and physicians of persons diagnosed with ADRD to collect more in-depth data, such as information related to the progression and treatment of the disease, service utilization, and caregiver characteristics. The registry was established and is maintained to provide disease prevalence estimates to advise and enable better planning for healthcare providers, patients, and decision makers in social and medical services. We use the registry to identify differences in disease prevalence among demographic groups to look at disparities. And on an basis, we release a report that provides detailed information on the number of ADRD diagnoses, a county level map, and breakdowns of ADRD by race, age, sex, and the location where they were residing at the time of diagnosis. We also seek to help formal and informal caregivers who provide care for individuals with ADRD by helping to inform our state's Dementia Dialogues program. This trains caregivers on proper care techniques and stress reduction. It also helps to assist with identifying areas where funding is needed for respite care and other dementia-related the state. Lastly, we help to foster research into risk factors for ADRD by using registry data and linkages to other health-related data sources. Next slide, please. So the big question is always, what data is available? Our registry contains information related to diagnosis, such as types of dementia, and data sources in which these cases were identified. We also have demographic data, location data, as in where they were residing at the time of diagnosis, either at home or in a nursing home, and location within the states. We have indicators for county and zip code. We also now have access to address at the individual's last hospital encounter for mapping purposes, mailings, and potentially for study recruitment as well. And then in terms of date variables, our registry contains information on year of birth, year of death, date of diagnosis. We do not house birth date or date of death, but we can apply for permission to use this for research studies. Normally, permission is granted to release calculated ranges, such as time of diagnosis to death, but date of death is not released due to confidentiality issues. So through our relationship with the Health and Demographics section at the Revenue and Fiscal Affairs Office, we're able to link our registry to various other statewide data sources. The availability of the data does vary by source. Release of information is under the control of the originating entity, and each of them has their own application process. Some of the most commonly used linkages with the registry are listed in the figure here on the right hand of the slide. Most of our sources go back to 1995, 96, or 2000, so they have over 20 years of historical data available. These sources include the Department of Health and Human Services that houses information on individuals in the Community Long-Term Care Program. Public Employee Benefits Program is also known as the State Health Plan, which offers insurance programs for over 500,000 people throughout South Carolina. The State Health Plan is the state's employee insurance program for South Carolina's public workforce, and it offers medical and dental coverage. So the State Department of Health and Environmental Control houses a cancer registry, HIV registry, and statewide COVID testing and diagnosis data. There is also an all-payer healthcare database, which includes inpatient and outpatient hospitalizations, ER visits, home health services, ambulatory surgery, and imaging information. In addition, we also have access to the Department of Mental Health and Corrections data for linkage. Next slide, please. So as we have heard from other presenters today, there are many ways that we can use registry data. Here in South Carolina, we have worked with our local chapter at the Alzheimer's Association to create county level fact sheets to highlight case information and geographic distribution down to the zip code level. These fact sheets are being used to educate the public and policymakers in an effort to obtain support for ADRD-specific legislation and policy changes. The registry is also used for larger, more detailed reports, like our annual report, that provides information on the number and type of ADRD diagnoses throughout our state, prevalence and risk estimates, breakdowns of ADRD by demographic groups, in addition to underlying causes of death and survival times. Registry data is enhanced by our ability to link to various other statewide data sources, as I mentioned on our previous slide. Through our linkages, we've been able to investigate topics like the influence of caregivers and behavioral and psychological symptoms on nursing home placement, the relationship between driving under the influence, Alzheimer's diagnosis and survival. We have also recently investigated the prevalence of dementia in the incarcerated population in South Carolina. So using address level data, we've done mapping studies using GIS, looking at the association between neighborhood characteristics and Alzheimer's. These focused on the mental health of caregivers and dementia symptomology among individuals with Alzheimer's disease. We've also looked at sedentary behavior in Alzheimer's disease caregivers. These caregivers were given an accelerometer and they wore it for a week and it recorded their activity levels. We found that caregivers spent almost 80% of their time sedentary and 85% of the sample were either overweight or obese. So current scientists from our last year's session are also using registry data to investigate underlying causes of death reported on death certificates for our registry cases, and also hospitalization trajectories after the onset of dementia. And you'll hear a lot more about those studies from them a little bit later on in the conference. So next slide. What can we do with registry data going forward? I feel like that's been a big topic here today. And on a national scale, developing a more comprehensive surveillance system similar to cancer registries is of the utmost importance. Rana mentioned that in her presentation previously. And also expanding the breadth of data acquisition for our current existing statewide registries would allow for more precision in our dementia prevalence estimates and our ability to investigate risk factors. So thinking into the future, registry data can be used to address some important gaps in research. Most of the statistics that we have come from before the COVID-19 pandemic. We do not yet know how COVID-19 has influenced Alzheimer's mortality, increased the burden of living with Alzheimer's disease, or how it influenced the caregiver's experience. Later this year, we will be receiving 2021 registry data, so we can begin our investigation of the impacts of COVID-19 on this population. Investigating case outcomes with different treatment strategies in diverse communities with or without comorbidities will help determine the most appropriate management strategy for individuals with dementia to improve the quality of their lives and their caregivers. So Dr. Friedrichsen mentioned that cost of care is a great issue, and it's a continuous issue that we should look at over time. So, are there potential savings from specific treatment programs or treating individuals that are at the earlier stages of the disease? These are important questions to answer that we can use our registry data for. So confirmatory diagnosis studies are also needed. Are the diagnoses we see in registries confirmed by autopsy or imaging studies? Are the Alzheimer's diagnosis truly Alzheimer's, or are they another form of dementia? We can use this data to look into that as well. And lastly, mapping is important to determine where cases are distributed geographically, to determine if populations are underserved by services, healthcare, and support networks for caregivers. It's also important to investigate how the social environment, the built environment, and the physical environment impacts populations with dementia and their care networks. And that is it for today. Thank you very much.
Thank you so much, Maggie, for your presentation and for your leadership. And we are going to move on to West Virginia. Thank you.
Thank you. Hi, my name is Bernie Shrews. I'd like to introduce you to the West Virginia Alzheimer's Disease Registry. As you've seen and heard from our previous speakers, Rana and Maggie, we have a number of guiding questions, and the first one of which is what we've accomplished with the Alzheimer's Disease Registry. Before I answer that question, let me explain that West Virginia is a relatively small state, and a lot of people know each other. Now, that's a good thing if you want to get something done, but it's probably a bad thing if you don't want someone to know what you've done. But in the field of Alzheimer's and related dementias, the West Virginia chapter of the Alzheimer's Association is a significant force in the state. And CEO Sharon Covert and COO Teresa Morris are really good people to know. The Alzheimer's Association is very active in West Virginia because people here are disproportionately affected by Alzheimer's and related dementias, in large part because so many folks have major risk factors for dementia. And of course, the most obvious one is age, but there's also diabetes, obesity, hypertension, unhealthy lifestyles, poverty, and limited education. In fact, unfortunately, West Virginia leads the nation in many, if not all, of these categories. So you can see in this slide that major accomplishments of the West Virginia Alzheimer's Disease Registry have been in using data for advocacy. We want to advocate for change. And here we partnered with the West Virginia chapter of the Alzheimer's Association. So you can see from this slide, there are two projects I'd like to highlight where our involvement helped bring about change. First, in 2022, we analyzed West Virginia Medicare data for local volunteers of the Alzheimer's Association who organized awareness campaigns lobbying state legislators in the House and Senate about the impact of dementia in the state. We focused on their individual electoral districts because, as a rule, the elderly vote more than younger people. And if you want to get a legislator's attention, talk to them about things that affect their voters. And as you can see, a law was passed in 2022 providing Alzheimer's and related dementia training for law enforcement personnel. The second project happened this year, but had its origins in one of the major limitations of our West Virginia Alzheimer's Disease Registry. You see, the registry was modeled after the state-based South Carolina registry you've just heard about from Dr. Miller. The South Carolina registry provided us with expertise, advice, and a copy of the legislation used to establish their registry, which we used to propose legislation in West Virginia. When it was finally approved and became law, a major difference between the South Carolina registry and the West Virginia registry was that here in West Virginia, legislators decided that all healthcare providers shall report cases of Alzheimer's and related dementias to the registry. One of our biggest challenges has been getting healthcare providers to provide those reports. In order to understand why that was such a hill to climb, if you will, we asked them through a survey that we set out to the West Virginia Practice-Based Network, or WVPBRN, which is a group of almost 100 primary care entities throughout the state that try to improve clinical practice based on research. Over 70% of those practices responded to our cognitive impairment questions on the survey, and these practices care for more than 120,000 people. We asked a range of questions about cognitive impairment in general, as well as more specific questions about the registry. One of the most pertinent questions, at least for my presentation today, was what practices needed to help their patients. Their needs included reliable information about cognitive impairment and dementia, training in cognitive assessment, consultations from specialists like neuropsychologists, information about social services, and information about long-term care facilities. We discussed our findings with the leadership of the West Virginia chapter of the Alzheimer's Association and with input from multiple stakeholders, including healthcare providers. The association advocated for West Virginia Senate Bill 526, which was subsequently passed into law this year. This bill essentially charges the Department of Public Health with educating healthcare professionals on the importance of early detection and timely diagnosis of cognitive impairment and dementia, encouraging the use of validated cognitive assessment tools, providing patients with effective care planning and care management at all stages of dementia, and delivering counseling and referral. So in this case, we were able to make lemonade out of some lemons. The next question was, what data are available in the West Virginia Registry? And in the next slide, you can see that we have historical data from 2012 to 2018 on patients with Alzheimer's and related dementia, amounting to about 28,000 cases. These data came from and continue to come from healthcare providers, at least in dribs and drabs, nursing homes, and the vast majority of those data are Medicare data, and they're all housed and administered by the West Virginia Clinical and Translational Sciences Institute. We're currently working on obtaining the most recent Medicare data. Importantly, the current Alzheimer's Association estimate of people in West Virginia with dementia is 39,000, which is actually below the 44,000 recipients of care in the Medicare database who have dementia. But this may be only the tip of the iceberg because there are many risk factors, including age, as I've mentioned, diabetes, obesity, socioeconomic and educational issues, which I've already mentioned, and suggest that published estimates of dementia in West Virginia are significantly short of the mark. In fact, the registry was originally developed to provide more accurate count, and we're still confronting that challenge. The next question is, how can registry data be used? So in the next slide, or the one that's up there now, you can see that one of our major uses of data is to provide information to stakeholders. This sort of information is very useful to patients and their caregivers, to healthcare providers, as we've already noted by our survey results, local, regional, state, and national organizations, particularly the Alzheimer's Association, with which we have a close collaboration, and local, regional, and state policymakers, as we saw with the law enforcement training legislation and healthcare provider Alzheimer's disease-related training. We've also learned that the registry's data can be used to effectively advocate for care for people with Alzheimer's disease. The final question is, what do we do with the registry data moving forward? Now, we have a range of suggestions here. The first and probably most important is to increase the accuracy of incidence and prevalence. The major question here is, how do we find all the people who are afflicted with dementia, given that at least here in West Virginia, not everyone goes to the doctor? In fact, healthcare at our primary institutions is wonderful and world-class, but when we get into more regional areas, and a lot of West Virginia is rural, healthcare providers may be a nurse practitioner or a physician's assistant. The second is that we need to increase healthcare provider participation. But how do we incentivize providers to participate in the registry? And I think you've heard from the Georgia Registry and the South Carolina Registry. One way to do that is to reduce the burden of reporting by accessing statewide electronic health records. Perhaps one of the most difficult issues, and as you heard from Greta Brown this morning, is overcoming barriers. For example, the stigma associated with dementia, the lack currently of an effective cure or even a treatment for Alzheimer's disease, and the lack of appropriate facilities, such as dementia specialty units in nursing homes. Finally, we need to do a better job of engaging our stakeholders. So as you can tell, we've had some successes, but also we maintain that we have a range of challenges to overcome in the West Virginia Alzheimer's Disease Registry. Thank you.
Wonderful. Thank you so much to Rana, to Maggie, and Bernie for sharing their expertise and leadership with us. A lot of common points across registries and a lot of common themes across presentations today, thinking about stigma, caregiver burden, etc. I saw that we had one question in the chat, and then I have a few questions. And if you have some more, please feel free to type them in the chat. Maggie, I believe Sarah wrote this question while you were presenting about one of the studies that was used with registry data, and it had to do with the accelerometers. What is the intended use for the data from the accelerometers on the caregivers?
This study was actually a follow-up to our initial study that interviewed 705 caregivers. So what we wanted to do is get a little bit more in-depth information about their activity levels. The accelerometer was actually an armband, and they would wear it for 7 days, 24 hours a day. And it looked at their activity levels, if they were getting vigorous activity versus moderate activity, and also sleep. So it was a monitor of their sleep as well. So we had just noticed that in the literature, there was very little, a little bit of information on caregivers and their activity levels, especially in Alzheimer's disease caregivers. So this was our opportunity to look at that a little bit more.
Excellent. Thank you for that response. You're getting some kudos in the chat for your presentations. Our next question is related to collaborations. Again, some common themes with Greta's presentation as well, and collaborations with stakeholders. This one is specifically asking about collaborative involvement with local health departments across the state regarding data contributions to the registries. I know you all touched on where the various sources of data come from. Who wants to take this question? Bernie, can I send that over to you first?
Sure. In West Virginia, the legislation talked about all healthcare providers, and when we obtain data from Medicare, for example, it's a state-based, because the registry is a state-based health activity, it's exempt from HIPAA, but we still have to go through the Department of Public Health to request those data. And so we have a collaboration with the Department of Public Health in West Virginia to allow us to access those data.
I can add, and this is a new initiative. We are the Georgia Alzheimer Registry, or ADRD registry, is within the Department of Public Health. We do work with our injury prevention program, who are tasked to do intervention. So we share data with our injury prevention program, and they have been working with local health departments on doing screening, educating our local health department. They have 2 pilot projects with local health departments to do screening for population on dementia. And we are still in the process of figuring out how and could we use this data as part of the central registry. So we will keep you in tune with what we're doing in the future, and hopefully it would be successful. Thank you.
Excellent. Thank you. Maggie, do you want to add anything to what Bernie and Rana have shared around those types of collaborations?
Yeah, I can just really briefly say, so in terms of our state departments, we are actually funded through the Department of Health and Services. So we've had a long-standing contract with them, and they fund our registry. Now, in terms of obtaining the data, we here at South Carolina have a really great structure set up through the Revenue Fiscal Affairs Office, and they have a data cube that houses multiple different statewide data sets. So, you know, we have Medicaid data, state health plan data, a lot of these sources that I was talking about in my presentation. So we work very closely with them, and on a yearly basis, we obtain all of the diagnoses from all of those sources in our state. So they're a state department that has a major role in our registry.
Excellent. Thank you for that. Bernie, we have another question for you here in the chat. Did the Alzheimer's Association help support the codification of the registry? Was lobbying in the vein of provider education?
No, we started the registry out of some research that I was doing on the effects of cholesterol, of all things, on dementia. And we could show how many people in the state had tainted drinking water, which was turned out to be a problem, but we could never find out how many people in the state actually had dementia. And that's why we started talking to folks at the time, Carol Kornman at the registry in South Carolina, and then moved forward with that. And at the time, the West Virginia chapter of the Alzheimer's Association was very, very engaged and invested in caregiver and patient advocacy. And I don't think they necessarily at the time, and this is some time ago, appreciated the potential of a registry. And it's only more recently, I think, with the advent of other registries and a change in leadership that an appreciation for what the registries might be able to do was realized. And since then, we've had a very, very close and mutually beneficial working relationship with the association. And the law enforcement training, for example, was something that they felt was important, and we provided the data for their advocates to go out and talk to the legislators, as I said.
Excellent. Great question and great background information. Thank you. There may have been a microphone cut off a bit before. I just wanted to reiterate what Maggie said. It's the South Carolina Department of Health and Human Services that funds the South Carolina Alzheimer's Disease Registry, just in case you couldn't hear that clearly. All right. All right, I have a couple of questions, if that's all right. And I think this group knew that I would. I'm always interested in the linkages across data sets and how that can enrich the research questions that we're asking, because we are going to be talking about more so this afternoon, how we can use the registry to inform research. What is the process like, and sort of decisions that were made on how and what data would be linked to for each of your registries? Rana, do you want to start with that one?
So when we decided to work on our Alzheimer linkage with the Georgia Violent Death Reporting System, there was at that time our GARD, which is our collaborative with stakeholders, were interested in safety. And we had these data sets, so we did that on our own as a central registry, since we had both the data from Medicare and our Georgia Violent Death Reporting System, and shared that data with GARD as well as with our Division of Aging and Injury Prevention. So for us, I mean, the researcher can reach out to me and kind of describe their protocol or whatever research project, linkage project they wanted to propose, and we can normally we will discuss it and see if this is feasible for the state of Georgia, because some of the data sets at this point, like Bernie said, is incomplete, and some of them have better way of linking. There is no general guidance of this. These are the data sets that need to be linked or can be linked. Is really on individual basis and based on research and the feasibility of that linkage with the Alzheimer registry or the ADRD registry in the state of Georgia.
Excellent, thank you. Anything else to add from our other registry managers, or ditto to what Rana said? Bernie?
A little bit of ditto, but also we were originally collecting PHI, identifiable information, and so we couldn't link our data set to anything else, quite honestly. But I think if we get to a position where we can de-identify the data, then we will certainly be able to share it with researchers. And an interesting thing actually happened with what Rana just said about the linkage between ADRD and suicide. One of the Department of Public Health and Human Resources here in West Virginia, slightly different name, read that paper, Rana, about the suicide connection and wanted to know if he could access registry data here in West Virginia to do a similar analysis, because he was very concerned about gun safety and the potential for suicide. It's interesting how these things are synergistic in some ways.
Excellent. In one or more of your recommendations, you mentioned national registry. And we are so fortunate to have these 3 statewide registries, and thinking about what that could look like to have a national registry focused on Alzheimer's disease and related dementias. In the ideal world, what would be the next step? Or in general, the real world, what would be the next step if you had your magic wand to move that forward?
Well, I think what Greta said is removing the stigma is so important. If we consider this disease like cancer, and we've talked among ourselves about cancer registries and how they might inform dementia registries. But I think that's a heavy lift right now. For lots of political, socioeconomic, and just practical reasons. There's an effort right now to establish Parkinson's disease registries as well. And West Virginia is leading that effort. But it turns out that Parkinson's has now become a reportable disease, as some of you may know, and Alzheimer's is not. And as such, the machinery that's not in place for dementia, but might be for Parkinson's, is something we would have to try and address.
If I may add to Bernie, I know I do agree that it is early to have a national registry, but my first step, and I've worked with cancer registry for quite some time, and from my experience, the establishment of this independent professional body that really discusses what is to be collected, how is it to be collected, when to be, all this who, where, when, why, and then working together with organization interested in ADRD to fund it, appropriately fund it. Without appropriate funding, we're going to continue to pull data, secondary data, like Maggie said. This is the best way to handle the registry, the ADRD registry at this point in time. But I wouldn't think this is what we need to go toward. We really need to be more into active data collection. If we agreed on what is the definition and standardize that definition across.
Thank you.
Yeah, I'd just like to reiterate too what Rana said. I think funding is a major issue. And over the years, we have consulted with, other states that were interested in registries and some other countries in Europe. And what it comes down to every time is that there is not sustained funding for a registry. So they might be able to create it, have it for a couple of years, and then if the funding's no longer there, there's no longer a registry. So sustained funding is very, very important. And as Rana was saying, having a group of stakeholders meet to really talk about infrastructure and what we would need at a national level. And then, of course, standardization of the variables that are collected so we can do national studies is of great importance.
Wonderful. Well, hopefully conferences like this can help keep the discussions going and see what can happen next, given the incredible work that the 3 of you and your teams are doing with Alzheimer's registries. Well, please join me in thanking Rana, Maggie, and Bernie for a fantastic session. We're going to break a few minutes early for lunch.